Our clinical rotation site was Stanford Hospital, Telehealth Center, Cardiac Rehab. The practical skills we performed were blood pressure during resting and exercise, EKG placement and interpretation, rate of perceived exertion, and health history. During this rotation, a topic we discussed that was presented in one of our undergraduate classes was blood pressure. This topic was presented in our exercise physiology class. This topic was presented dually in both lecture and lab portions of this course. We learned blood pressure norms, which is categorized as 120/80 millimeters of mercury. Prehypertension is considered to have a systolic pressure between 120 and 139, and diastolic between 80 and 89. Stage 1 hypertension is considered to have systolic pressure between 140 and 159, and a diastolic pressure between 90 and 99. Anything with a blood pressure over 160/100 millimeters of mercury is said to be considered stage 2 hypertension. The top number, or systolic pressure, is the contraction of the heart that forces blood out into the body. In contrast, the bottom number, or diastolic, is the relaxation and filling of the heart with blood. In exercise physiology, we were able to practice resting and exercise blood pressure skills on multiple occasions during lab and lecture portions of the course. Blood pressures at the cardiac rehab site were taken pre and post exercise as well as during exercise if needed. The numbers taken were evaluated and compared to the norms for each individual to clear them for exercise, as well as to ensure the patient was stable and asymptomatic post exercise. Once we obtained the information, we discussed with each patient what should happen with systolic and diastolic blood pressures after exercise. Systolic blood pressures should stay the same or rise slightly, while diastolic blood pressure should stay the same or decrease slightly. The article we looked at was Safety of Medically Supervised Outpatient Cardiac Rehabilitation Exercise Therapy, a 16-year follow-up by Franklin and colleagues. What we observed during our clinical rotation was ECG monitoring and interpretation during Phase 2 cardiac rehab with exercise. This monitoring was done to ensure that no adverse cardiac events were occurring during exercise, and so that if one did occur, it would be caught and treated early with on-site medical staff. Prior to exercise, all patients during Phase 2 cardiac rehab are placed on a 3-lead ECG transmitter, which shows real-time ECG rhythm strips and is monitored at all times during exercise by exercise physiologists and nurses. In the article presented by Franklin and colleagues, they demonstrated that the prevalence of adverse cardiac events during exercise as compared with rest may be up to 100-fold greater. They also observed that myocardial infarctions can be 2 to 6 times greater during exercise in cardiac rehab patients as compared with less strenuous activity. After obtaining this information, it can be concluded that the ECG monitoring may be able to reduce the prevalence of such events as well as to rule out non-cardiac related symptoms. ECGs are objective method of measurements in that the presence or absence of symptoms, any abnormalities of the heart will appear in real time. The ECG monitoring is not only beneficial to on-site staff, but also the patient's cardiologist and primary care physician. From our experience in the field, as well as what we learned from the exercise physiologists, another limiting factor to exercise is the psychological aspect of what happens if the patient begins experiencing symptoms of a cardiac event or other complications. Being in Phase 2 and being monitored continuously by ECG gives each patient an opportunity to exercise without psychological limitations that they would have on their own.